Hi, I'm Alicia O'Cahorn and I want to talk to you today about what happens when we see a service, an initiative, a model of care in one context and we want to use it in our context. So, for example, we look at Germany. They have a great system for centralising stroke care. They've evaluated it. They've shown it to be highly effective at reducing mortality rates for stroke. And we want to bring it over to the UK. And that sort of situation is highly relevant to HSR. And we have written some guidance about how to take evidence-informed interventions from one context for use in another context. So the guidance was written by a large group of people. I'm merely presenting it today on behalf of that large group of people, and it was led by Graham Moore and Rhiannon Evans from the University of Cardiff, and it was funded by the MRC NIHR methodology panel. Now, it's a good idea to look at what is done in other places, in other conditions, so that we are using the evidence base that we already have in the most efficient way possible. And when we find an intervention or initiative that we think we can use in a different context, we really have to think about the fit of that intervention to the new context. Just how different was the original context to the current context we're thinking about? And if we make a large number of adaptations, or make one single very large adaptation, are we damaging the fidelity of that intervention? Are we really using the same intervention or a totally different intervention? And another dilemma that we face is, if it's been evaluated elsewhere and shown to be effective, shown, for example, to reduce mortality, why do we need to evaluate it again? Do we need to evaluate it again? So all these questions need to be considered when we're in this situation. So we developed guidance to help us think through these dilemmas. They help us think them through. They don't actually give us the answers, because so much of this decision making depends on the situation that we find ourselves in. And I'll explain that in future slides. So we developed the guidance in three ways. The first thing we did was we looked at the guidance that was already written, and we found 35 guidance papers that we were able to bring together and synthesize, so to use all that expertise that was already there. We also looked at how people did this in practice, and we found 28 cases of papers where people described the adaptation process that they took. We also interviewed experts in this field, people who had done these kinds of adaptations, evaluated these kinds of adaptations, funded them, for example. And then we used those two knowledge bases to undertake a Delphi of experts in the field, asking them how we should go about adapting interventions. Now, the detailed guidance is on a website at the University of Cardiff, and I've given you the link there. We've tried to set it out as simply as possible, and we have devised a set of recommendations and a checklist to allow individuals to think through all the issues when they are thinking about adapting an intervention. An important thing to consider is getting together a group of stakeholders at the beginning of even thinking about adapting an intervention, and then thinking about how that stakeholder group should develop over time as the types of questions you face as you progress through the adaptation process develop. So these stakeholders might be people who have developed or evaluated the intervention in the original context. They might be the stakeholders from your new context, people who might deliver the intervention, who might fund the intervention, policymakers, patients who might receive the intervention. And it's about bringing them together to think clearly about what might need to be adapted over time. The guidance considers when you have a number of interventions that you might want to bring into your new context, and you might have to weigh up the strengths and weaknesses of these different interventions and select the one that has the most robust evidence base and the strongest outcomes. Something that people do when they're adapting interventions is to look at the differences between the original context and the new context in which they want to use it. And they start to see just how different those contexts are, but they forget to look at the similarities of those contexts. And something that we say in the guidance is, don't overestimate the differences between the contexts. Don't necessarily think you have to adapt absolutely everything because the contexts differ. It's good to see the similarities between the contexts as well, and to think about the aspects of context that actually count and might contribute to gaining outcomes from your intervention. When thinking through the dilemma of whether making large numbers of adaptations will damage the fidelity of the intervention that you want to use, it is worth thinking about Penny Hawes' function and form of an intervention. So, for example, if you are trying to educate patients about a particular aspect of their care, that's the function. You may do it differently in Germany from the UK. You might choose to use a paper format in one country, but a digital format in another. So the form might be different, but the function is the same. And if the function is the same, then you are not damaging fidelity. So what our guidance does is try to sort of remove us from this damaging fidelity or maintaining fidelity spectrum, and think more widely about what we are actually adapting. So should you re-evaluate this adapted intervention? We recommend that you certainly test the feasibility of it, because your stakeholder group might have identified a large range of adaptations that are needed, but they might have missed some key issues that you can only really understand about when you try it out in practice. The whole dilemma about evaluating the intervention and what type of evaluation that you might need depends on the robustness of the evaluation that was undertaken in the original context, the extent of the adaptations that you might have made, and you just really need to think about your particular situation. Often when we're adapting these kinds of interventions, we really have the longer picture in mind. How can this adaptation be used at scale? So we're not just thinking about using it in one stroke service in a region in the UK, we're thinking about using it UK-wide over the longer term. And it's important to go back to that stakeholder group that we talked about at the beginning, that the people who will maintain the intervention in the longer term and ensure its progress need to be part of that original stakeholder group. And you also need to think about how to monitor the outcomes of the intervention over time. And this is where large, routinely available data sets come into their own. That would allow the UK, for example, to monitor stroke mortality over time. Now, what I found really interesting as a health services researcher engaging in developing this guidance was that we focused the guidance on population health, and we described this as both public health and health services research. Yet when we were looking for examples of this in the literature, we could only really find health promotion, public health, and access to screening. So the access to screening starts to come into the territory of health services research, but isn't really health services research. And my question was, where's all the health services research that adapts interventions from other communities, other countries, for example. And I thought, well, perhaps we use different language. And I know that we don't tend to use the term intervention. In health services research, we might talk about initiatives and services and aspects of services like workforce. But we used what I would call sort of broad language in our search terms. So it wasn't that we were just looking narrowly at interventions, as they're called. And then I thought, well, perhaps in public health, researchers are more likely to look at an intervention that's used somewhere else and try to adapt it for a different context. Maybe policymakers and service providers do that in health services research. And as researchers, we're called in when they've done the adaptation and we're asked to evaluate what is given to us as a new model, a new service. And I've thought about this, and I actually would really benefit from a discussion about it. And there is a live session on the 6th of July at 3:15 in the afternoon. And there I will pose a few questions about it, but I really want to hear your views about how relevant this is to HSR, because I think it's highly relevant, and how it fits in, and how it fits in with the context of health services research. So thank you for listening, and hope to see you on the 6th of July.